next talk will be an online one by Pramod Garg about the organ failure in acute pancreatitis, a call for action.
Hello, good morning, everybody. Can you hear me and see my slides?
Perfectly, we can hear you. We can see your slide. Hi, Pramod. Good afternoon. Hi. Here in Hungary, in Budapest.
So, good morning, everybody. I'd like to thank the organizers, in particular Peter Heggie, for giving me this opportunity to talk about organ dysfunction in acute pancreatitis. I'm actually missing action physically there, missing my friends, but I think in near future, you might get another opportunity to meet and greet each other. So the job that I've been assigned is to discuss organ dysfunction in acute pancreatitis, and I have no disclosures to make here. So let me begin by showing you something that everybody talks about nowadays. You have a large fluid collection called walled off necrosis. You have a new kid on the block. That's a hot axios stent. And you get a patient with acute pancreatitis, maybe infected necrosis, and all over world, all the conferences will show you live, how do you puncture this? How do you put a metal stent which will drain out everything? And then you do necrosectomy endoscopically in a minimally invasive fashion, and how the patient will improve. So this is nowadays being shown as the treatment for acute pancreatitis, and everybody would clap whenever you have a live endoscopy workshop or other endoscopy related conferences. Now, so this is the way you do necrosectomy in them, and this is being touted as a cure for acute pancreatitis. Of course, the reality is much different, as I'm going to discuss now. So we all know that acute pancreatitis is associated with both local and systemic injury, and it is the systemic injury which results in organ dysfunction. So what is the mortality in acute pancreatitis? Some would say it is 1% or even less, and someone say the mortality may be as high as 40 to 50%. So how do you interpret that? It depends on what do you look at. What do you want to report in your studies? So this is a series from Harvard published many, many years ago, 1,100 patients, 9% had necrotizing pancreatitis, and the mortality was 1.3%. Another series from UK, 759 patients, 42% mortality due to persistent early organ failure. See the remarkable difference. So this is a scenario of a 62-year-old lady who came with abdominal pain for 2 days. CT shows acute pancreatitis, 30% necrosis. She was hypertensive, somewhat obese, hospitalized, recovered soon, and were discharged by day 6. There was no problem. On the other hand, here is a young male, no comorbidities. He had abdominal pain for a day, developed respiratory failure on day 2, renal failure day 3, hospitalized in ICU on a ventilator, dialyzed, but died by day 7 or day 10. So organ dysfunction clearly is a major problem. So many years ago, we published a study and characterized the newer subgroups of patients who had fulminant, what we called as fulminant or subfulminant pancreatitis associated with high early mortality. We had 282 patients who had what we called early severe acute pancreatitis. This term was used first time, I think, from Germany in a series of patients. So we divide patients to 2 groups, fulminant and subfulminant. Fulminant as someone who developed organ dysfunction, grade 3 or 4, within 72 hours, and subfulminant who developed it a little later. And those who had organ dysfunction later was termed as late severe pancreatitis. What we found was that 11% of patients accounted for or 44% of all deaths within the first 8 days. And this was at a time when necrosis and infection were either absent or evolving. So early persistent organ failure is the most important thing. We analyzed our data of more than 1,300 patients over 16 years, and we found that although overall mortality still remains high, although adjusted for severity, it decreased to some extent, but still it is around 20 to 25%, given the fact that ours is a tertiary care referral hospital. So this is the most important determinant of survival. One of the questions is, it is organ failure, what time it develops, early or late. And we all know there are two peaks of severity in patients with acute pancreatitis. In the first phase, you have all the perturbations going on, which result in organ dysfunction. And these also may lead to local injury with necrosis. Later during the course, you may have infected necrosis, which may also cause late or secondary organ failure and death. Now, during the last 2 years, what COVID-19 has taught us is cytokine storm. Everybody talks about cytokine storm, which we have been discussing in our pancreatology meetings for quite some time. That what is cytokine storm? How does it lead to, sudden massive increase in cytokines leading to organ dysfunction? And this is what is now being realized is the major cause of organ failure. So one of the question comes in that what is the cause of organ failure in acute pancreatitis? Pancreatitis itself, which is sterile, or sepsis. So the conceptual model is that you have tissue injury, which leads to inflammation. Inflammation, when severe, leads to organ dysfunction. You have, for example, an acute event, which could be infection, trauma, or pancreatitis. This leads to local inflammation and tissue injury, leading to release of either PAMs or DAMs, and which is a pro-inflammatory response. And this may result in some patients with systemic inflammation as the cause of organ failure. Some patients may have a second hit, which may result in further organ dysfunction. So in the context of pancreatic inflammation and tissue injury, which is necrosis, you have release of DAMs, or as Vijay would put it, unsaturated fatty acids as well. Then this causes systemic inflammation. This leads to primary organ failure early in the course of the disease. And those patients who develop infected necrosis may have secondary organ dysfunction. This is the conceptual model for organ dysfunction in acute pancreatitis. So we studied what's the differential role of primary and secondary organ failure and mortality in these patients. There were a total of 614 patients with a mean age of 38 years. And what we found, I've shown you this earlier. Let me put numbers here. Total of 614 patients, 177 developed primary organ dysfunction, and 283 developed infected necrosis. Of them, 97 developed secondary organ failure. Mind you, these are data from a tertiary care hospital with a referral bias. And that's why the percentage of patients having severe pancreatitis is high. And when we analyze these patients, of those 177 who had primary early organ failure, 15.8% died very early. And those who survived, 76% developed infected necrosis. That means primary organ dysfunction is a risk factor for infected necrosis with a high mortality of 42%. Among those who had no organ failure here and no infected necrosis, there was no mortality or hardly any mortality. So it shows here that mortality is governed either by primary or secondary organ failure. When we compared our data with other series published during the same time, in fact, our paper in 2018 showed 42.7% mortality in patients with persistent organ failure. Data from Dutch group showed 38%, which was published in Gut. And this is the data from Spain, which showed 52% mortality in those with persistent organ dysfunction. So up to 40% patients will die if they have severe pancreatitis. So what do we need to do to decrease mortality? So systemic inflammation is a critical element which requires targeted therapy. Where are we as of today? So what do we do as of today is to treat such patients in the ICU. The patient is put on all kinds of organ support. We call the intensivist. We pray and hope for the best. What has happened, however, over a period of time is gain in knowledge that we have moved from trypsin and cathepsin B to impaired autophagy and ER stress, mitochondrial dysfunction resulting in acinar cell stress and injury. But these improvements did not translate into patient benefit. Do we have any treatment, any pharmacological treatment? Unfortunately, none. In a Cochrane review of 2017, 78 trials were included, having 7,366 patients. Pharma companies funded only 21 of these trials, and there was no difference in mortality with any of the treatment. Many therapeutic trials with antibiotics, nutrition, type of fluid were done without any benefit. Specific target therapy were also tried, but there are many celebrated failed attempts, including lexipefent, probiotics, activated protein C, and ulinastatin. Pentoxifylline showed some benefit, a small trial of 28 patients, but a larger trial from the same group showed no benefit. I checked the WHO trial registry on clinical trials in acute pancreatitis, and I was very happy to see the Hungarian group publishing so many clinical trials. That's very heartening, and I must congratulate them for doing such wonderful work. Of the 263 trials on acute pancreatitis, there was some on therapy, which included fecal microbiota transplantation, Chinese decoction, plasmapheresis, non-specific anti-inflammatory drugs, and a couple on methylprednisolone. I'm not sure we are going to have much benefit from the ongoing trials. So what is the future? The future is the newer concepts about the pathways causing organ dysfunction. And in this regard, targeting cytokines seems to be quite useful. One is TNF-alpha, and there is an ongoing trial in the UK on infliximab. IL-6 is another target. Immunomodulation, targeting the NLRP3 inflammasome, could be another. Cytosorb, which is extracorporeal removal of cytokines. I know there's a trial going on in Germany. IL-6 seems quite promising. We showed many, many years ago that IL-6 on day 3 correlates with organ failure. And more recently, we found that in the presence of SARS, if you have high IL-6, it predicts organ failure. And IL-6 value of more than 160 picogram per ml was found to be associated with high positive predictive value and specificity. There was a paper many years ago that how IL-6 transcycling pathway is involved in organ dysfunction, and inhibition of IL-6 could improve survival in animal models. And I think this needs to be tested in humans as well. I'm not aware currently if there's any trial going on. So the newer concepts are about unsaturated free fatty acids, which is working on that. Calcium CRC inhibitor, we heard a talk this morning in acute pancreatitis and COVID. Coagulation pathway may be involved. Tryptophan metabolite, in particular kynurenine, was also shown to be associated with organ failure. And I think there is something needs to be done in that pathway also. So I think Vijay is going to give a talk on unsaturated fatty acids. My only problem here is that we don't know how to remove these unsaturated fatty acids early in the course of the disease to prevent organ failure. So what do we need to do in future if we have to decrease the mortality due to organ failure? One is that we need to shift our attention from pancreatic enzymes to cytokines. We also need to shift attention, and I'm sorry about basic biology sitting there. Their work on acinar cell is huge and I think hugely important. But when it comes to organ dysfunction, I think we need to discuss about inflammatory cells, which are the cause of systemic inflammation and organ dysfunction. We need to also develop very good animal models of severe pancreatitis with organ failure. So in general, when we talk about severe pancreatitis in animal models, we are showing some necrosis in the acinar cells and say this is severe pancreatitis, or some histological changes in the lungs to say it is severe pancreatitis. I don't think that is good enough. So we need to actually monitor the physiological parameters and say the animal has actually developed organ dysfunction. In this regard, we recently developed a rat model of severe acute pancreatitis where we cannulated the carotid artery and measured the blood pressure, oxygen saturation, and other vital parameters. And we are testing some of these targeted drugs to inhibit systemic inflammation. And lastly, when we identify these targets, I think then develop inhibitors. And to my mind, involvement of industry is very important to take this forward. So ladies and gentlemen, I'd like to summarize by saying the mortality remains high in severe pancreatitis due to early and persistent organ failure. Current research is inadequate. We have to have renewed efforts to identify key pathways and develop targeted therapy if we were to decrease mortality from organ failure. A hot axial stent putting in patients with infected necrosis is not the solution to decrease early mortality. Thank you for your kind attention, and I'll be happy to take questions.
Thank you very much, Pramod. This is a great lecture, and Ashok.
Thank you, Pramod, for a very lucid lecture. Even I learned it something which is not that easy, but thank you. So I have a couple of questions. First, I know there's a trial for TNF-alpha, anti-TNF, and IL-6. Most of them have not yielded anything. And obviously, there are so many different cytokines and chemokines and other agents which are causing inflammation. And these compensatory responses. You block one and there are 6 others which cause. We have similar problem in cancer. You block one and there's compensatory responses. For example, there are a lot of trials where in cancer, they have inhibitors for HSP90. A long line of inhibitors have been tried. You block HSP90, HSP70 goes off the roof, and there is no protection. Similar thing in pancreatitis happens. All of these chemokines, cytokines, and their involvement, we know that in 1890s, Jim Norman had shown this beautiful profile, I think it was in early 90s in clinical pancreatitis, but nothing has come out. And I am not sure that blocking, IL-6 or TNF-alpha will make a change. So my second question is about microbiome and infected necrosis. So we know now more and more work is coming up that microbiome is very important, and what happened in gut, and that's probably caused infection. Now the question is infection, is this a consequence that you have a pancreatitis and then you get these bugs moving in, or bugs are moving in from the gut and that causes pancreatic problem? So it is cause or effect in that case. They are both sides of stories, that you give Cerulean pancreatitis, there's more there are more microbiota, more gut permeability is changed. You give opioid, we showed that changed gut biota. So there's all kind of data on this, and I'm not sure where we are going with that also. So maybe if you can tell us a little more about those things. Thank you.
Thank you, Dr. Saluja, for these very important questions. So first is about cytokines. And I agree with you that once you have a plethora of cytokines and chemokines being released, it's often difficult to say which one to target, or target one or many. I think the example that we have from inflammatory bowel disease and from many rheumatological diseases where they have targeted one particular cytokine and shown excellent results, both with TNF-alpha antagonist and IL-6, I think that tells us that even though there are too many, there is one which is the driver cytokine or the main cytokine. If we can block that, we may decrease inflammation. So currently, these monoclonal antibodies, the ones which are being used in all rheumatological diseases and IBD, have actually shown much benefit. And to my mind, that could be the case with pancreatitis also, but obviously we need to have many studies in this regard. The second is that another approach which one could take is to remove all or major pro-inflammatory cytokines or chemokines by way of, say, plasmapheresis or, say, cytosol. I showed you one trial going on in Germany. And then you may have a desired effect, or use something like steroids, which not only suppress one cytokine, but in general, pro-inflammatory response may be suppressed. And actually, in the animal model that I've just shown you, we have found methylprednisolone to have significant beneficial effect. The only problem people feel is that it might lead to immunosuppression and may promote secondary infection. But I think that also needs to be studied. And that brings me to your second question on microbiome. So what is generally believed is that in the early course of acute pancreatitis, within the first 3-4 days, it is mostly sterile inflammation. Whether or not we have non-culturable bacteria or other microorganisms coming from the gut and causing or increasing the systemic inflammation, we don't know. If you do blood cultures, which is a poor technique to find out early infections, they are mostly sterile. We hardly find any culture positive. So I think the research currently is inadequate to find if gut microbiome or microbiome in general is causing early systemic inflammation or not. I think we need definitely more research in that.
Has there not been trials? I mean, obviously I'm not a clinician,
so,
but for steroids, for example, I thought that's kind of for pancreatitis, a failed therapy.
So no, so I don't think there has been any major clinical trial on steroids in acute pancreatitis, at least for last 15, 20 years that I can remember. Maybe I have missed some abstracts, but I don't think there has been a trial. Animal studies, yes, there are many animal studies which have shown benefit of steroids. And I think this requires more attention, whether steroids or another biological agent.
But why is that? Why steroids have not been tried? I mean, you know,
because everybody's scared of steroids.
It should be the easiest trial to do.
Because everybody's scared of steroids. Everybody feels you give steroids, it will increase your chances of secondary infection. It will increase your blood sugar, major problems. But now I think the world has understood in the case of severe COVID that even in infectious diseases, you can give steroids with very good results. Similarly, in frank sepsis, many trials have shown some benefit of steroids, although not much decrease in mortality, but some benefit. So I think we need to do some trials on this in acute pancreatitis as well. Yes, Julia.
Thanks, Pramod. No, I was just wanted to add that I'm in intensive care, and severe acute pancreatitis is obviously treated in intensive care. Steroids are used. I mean, they are, if there's a vasorefractory shock and you need catecholamines, you will do a steroid perfusion. So it's daily clinical practice, just applicated differently. And to my knowledge, there have been trials, but they are from Russia and they date back to the 1970s, and they are even placebo controlled, but they couldn't show an effect on mortality. At least this is what I found out when I researched that many years back.
Thank you.
Thanks, Pramod. This is Maisam Abu-El-Hajja, Cincinnati. I wanted to comment on some of the utility of the data that you showed when we're designing the next phase of clinical trials. So if I want to use the IL-6 as an example, when we tested chemokines and cytokines on these patients on presentation, they all looked the same. At the time of presentation, you cannot tell who is going to have an early organ failure or even late organ failure. And then when you test the IL-6, the elevation of it in the patients who will later on develop organ failure is only present in 20%. And these are your patients who are going to go south. But then even within those patients, so risk stratifying, when we design trials, we need to be able to measure that on admission so that we're able to risk stratify who's going to benefit from that. And then later on, even within those same subjects, the level of elevation doesn't always indicate, you know, how would you block it and when, because there is very short window by which you can intervene, and this is the driver of the rest of the cascade. I'll show some of this in my presentation later too.
Thank you. I agree with you. The window of opportunity is actually very short. And there is a plethora of chemokines and cytokines. And that's why I'm saying that we need to really identify which are the ones which are the driver cytokines pushing the systemic inflammation. But I think there is a meta-analysis on IL-6 which has shown this to be really very, very good in predicting who develops organ failure or not.
Hey, Pramod. Hi, Marco here. I was a little bit puzzled by your discussion. Do you really now hypothesize that pancreatitis does not start as a sterile infection?
So that's what I'm saying. So I don't know. So what we currently believe that it is non-infective sterile inflammation.
Yes, absolutely. But I was puzzled by the fact that you kind of doubted that I agree that microbiome can be very important with regard to the chance of secondary infection. But I hope we do not kind of discuss, or we put at discussion, that the fact that pancreatitis starts as a sterile infection.
So I agree with you. And that is why I think all the randomized trials of prophylactic antibiotics actually fail to show any benefit in terms of mortality. So I agree with you. But what I was saying is that if there is any role of microbiome, means non-culturable bacteria circulating and increasing inflammation, I don't know. I think that needs more study.
Thank you very much. Thank you, Pramod. It was very nice to have you with us, and we must be going on because we're a little bit late.